welcome to the stage Dr. Nupur Raj. She is going to present on multiple myeloma, a pathway to better outcomes. And this presentation is an educational session that's sponsored by an educational grant from Celgene. Dr. Raj, welcome.
Thank you so much, Patty, and thank you for this invitation. This is what I'm going to do. I do think it's time to think about creating pathways and figuring out how we're going to be paying for the things that we use for our patients. And multiple myeloma does get a lot of attention because of the high-cost drugs. So I'm going to kind of walk you through what we have available for myeloma and then give you my perspective on how we should be valuing all the different options that we have. So before that, these are just my conflicts, and from the learning objective standpoint, we're going to walk through treatment of myeloma, and if untreated, what are the outcomes, evaluate some of the clinical trials that we have, and look at some of the pharmacoeconomic profiles of the newer treatments, which are all sort of high-cost drugs, specifically in the space of multiple myeloma. What I am going to do over the next 40 minutes or so is kind of walk you through myeloma, because this is not what you do on an everyday basis, and multiple myeloma is not that common a disease. Amongst the heme cancers, it is actually the second most after lymphomas. I think what has changed, though, over the last several years is the fact that patients are living a lot longer. So at least in the United States, we have about 30,000 people who are diagnosed with multiple myeloma on a yearly basis. But given that people are living that much longer, at any given time, we have more than 100,000 people living with myeloma and on treatment with myeloma. I'm not going to go into the details of what myeloma is all about, but essentially it's a syndrome wherein two big factors, kidneys and bones, are important. People can have a lot of bone-related problems, compression fractures, cord compression, bone fractures, and a lot of patients, if left untreated, can develop renal failure and be on dialysis. This is what the natural history of multiple myeloma looks like. We have a stage where you have active disease, and then over a patient's lifetime, these patients, we're pretty good at getting them into remission, but they will relapse, and they relapse over, the relapses could be several over their lifetime, to a point where they end up developing relapsed refractory disease. Now, what happens to people if they're left untreated or if they're even suboptimally treated? Well, myeloma is an immune-related problem, and you will end up with a lot of problems such as infections. So pneumonias is very common. In fact, one of the highest cancer-related mortality from pneumonias is seen in patients with multiple myeloma. I've already talked to you about bone disease, which can result in a lot of morbidity and actually increases mortality twofold in these patients, renal failure and dialysis dependence, and ultimately relapse and refractory disease. I think why myeloma gets so much of attention is the fact that we are in a fortunate place here. We have a lot of FDA-approved drugs. But before I talk about the FDA-approved drugs, I think what's also happened is the platform for monitoring and diagnosing this disease has also improved. So we have the diagnostic and monitoring platform. Then we have several of these drugs which have been FDA-approved. So if you look back over the last 10 years or so, we have at least about 12 to 15 combinations which have been approved in the last 8 to 10 years. The class of drugs of the proteasome inhibitors, so bortezomib, carfilzomib, ixazomib. Then you have the IMiDs, thalidomide, lenalidomide, pomalidomide. We had combinations such as Doxil with bortezomib, panobinostat with bortezomib. Most recently, we have two monoclonal antibodies which are approved. So elotuzumab as well as daratumumab, and Melphalan is a drug which we've used for more than 60 years, finally got an approval in 2016 as well. So I think we've done a good job in getting clinical trials done, getting these drugs approved. But remember that I'm going to show you data with combinations suggesting that these are all high-cost drugs. So how does one think about treatment for myeloma? And I'm just going to kind of give you the principles here. When you have a newly diagnosed patient, you think about transplant eligible versus ineligible. You induce a patient, you transplant the transplant eligible patient, and then you maintain a patient. And if it's an older patient, you start with initial therapy, and there's more and more data to suggest that you're needing to continue treatment. And I showed you the natural history of myeloma, wherein you have multiple relapses. And the good news is we have treatments at the back end as well. And supportive therapy is something which is required pretty much throughout the lifetime of a patient with myeloma. So what is standard practice in 2018? Well, most of us use combination approaches in the newly diagnosed patients. It's a combination of either RVD, KRD, VCD. These are just combination new drugs that we're using. Transplant and maintenance has become pretty much standard of care. Very recently now, we have a monoclonal antibody like Denosumab, which was just approved, FDA approved, even in the upfront setting. And even for the relapse space, we're using triplet combinations of these novel drugs to get our patients into remission. So where is the data to support all of this? What we do know over the last kind of 6-7 years now is the fact that when you combine drugs in patients with myeloma, you're going to get 100% of these patients respond. And with 100% of these patients responding, we are seeing very high complete response rates as well. About 50 or 60% of these patients actually have a complete remission, which is a good thing for myeloma. Now, if you get to a level where you're having half of your patients respond so well, should we be looking at even a better way of assessing response? And what we've done in multiple myeloma now is started looking at minimal residual disease, and we have different ways of looking at minimal residual disease. And the reason to look at that is this diagram here, which kind of tells you all you need to know about why you should be looking at depth of response out here. When folks are diagnosed with multiple myeloma, this is what the disease burden looks like. And what you're really seeing is just the tip of the iceberg. And when you try and treat these patients with multiple myeloma, even when they go into a complete response, this is the number of myeloma cells still existent is as high as this, 10 times 10 here, and this is partly the reason why patients will relapse. And as you keep giving treatment, so high-dose therapy, high-dose chemotherapy only gets people down to this level. There's more reason to treat because there's a lot of subclinical myeloma, which is in fact responsible for that relapsed refractory disease state. And therefore, even when you go into a molecular remission, which is what you see out here, you see there's a lot of disease burden, which is again responsible for the development of relapsed refractory disease. So this is data which is actually very useful, and we put this together, and this is sort of agnostic of how does one get to MRD status. But the point here that I want to make is the fact that if you get to MRD negative, it not only impacts your progression-free survival, but it also impacts your overall survival. And this is important, and this is something we went back to the regulators with in terms of trying to approve drugs early, in using markers such as MRD negative status to get drugs approved, so you do not have to wait the 2 and 3 years to look for a PFS benefit, because this correlates nicely not only with the PFS but also with overall survival in patients with myeloma. So how are we doing with the 3 drug combinations that I just talked to you about? I showed you that with the majority of these, we are getting a complete response of about 50%. But if you look at MRD negativity in those folks who achieve a complete response, we're not doing that great. We're seeing only about 50% of those patients actually becoming MRD negative. Again, underscoring the fact that we have a lot more in terms of improvement in the treatment of multiple myeloma. I'm going to show you a few examples of where the data is and what leads us into how we take care of our patients here. This was a question on transplant, and the question being asked is, well, you're doing so well with new drugs now, do you even need a transplant in patients with multiple myeloma? And this is what the data looks like. The response rates favored transplant, and when you look at the progression-free survival, it actually favored the transplant quite significantly. No difference in overall survival, though, suggesting that, I think we just have to wait long enough. We did look at MRD status here. Now remember, only 50% of those patients who achieved a CR were MRD negative, but the folks who were MRD negative did way better than the ones who were MRD positive, again underscoring the fact that maybe MRD negativity should be what we should be aiming for. And even with the 3-drug combinations that have sort of become the standard of care for multiple myeloma, only about 50% of those patients who achieve a complete response there will achieve this MRD negative status. Moving forward, we have a lot of clinical trials where we've compared 2 drugs with 3 drugs. This is an example of a cooperative group study, SWOG study comparing RD, so 2 drugs with 3 drugs, RVD. And the important thing here is a benefit not just in progression-free survival, but an overall survival advantage, suggesting that 3 drugs should be the way to go. Again, even if it's a more expensive regimen, given that we're seeing a survival benefit here, nobody ethically could be using a 2-drug combination in patients with multiple myeloma going forward. There are other drugs which I'm going to go over quickly. This is the KRD regimen, phase 2 data. We still don't have phase 3 data just as yet, but the data looks excellent, wherein at a 2-year, the survival of these patients, or the progression-free survival, is in excess of 90%. The other thing which is new and not quite new, has become sort of standard of care in myeloma, is the use of maintenance therapy. I showed you that iceberg analogy earlier on with multiple myeloma, and this is sort of kind of reframing that. And if you look at treatment, induction, transplant, consolidation, you get your disease burden down so much. But this is why the disease relapses, while if you put patients on maintenance, you deepen that response, and the chances of these patients progressing is pushed out that much longer. So based on that, we are now using maintenance, and this is again been approved by the FDA. We did a meta-analysis with 3 different studies put together out here, and the bottom line here was we looked at more than 1,000 patients here with a median follow-up of close to 80 months out here, and this demonstrated a survival benefit for patients with a risk reduction in death by about 26%, representing an increase in median survival by 2.5 years. So maintenance treatment is in fact impacting overall survival in patients with multiple myeloma by close to 2.5 years. And this, when the FDA looked at this data, they've approved lenalidomide maintenance as standard of care for patients with multiple myeloma. But what about this? So this is all good for the transplant-eligible patient population, but what about the older patient population? And really, the majority of multiple myeloma patients is that older patient population. About 60% of patients are above the age of 65 or are not transplant eligible, so everything that I've shown you does not apply to the majority of myeloma patients. What about the data there? Well, even in the older patient population, we have old data looking at complete responses now, and complete responses translating not only in benefit in terms of disease-free survival, but more importantly in terms of overall survival as well. So we took a triplet regimen here. This is an example of RVD Lite, and we used this in patients wherein the older patient population, which was a non-transplant eligible patient population, had an overall response rate of in excess of 80%, with more than 65% of these achieving a very good partial response, translating into a very nice PFS and an overall survival and a PFS of up to 36 months, and an older patient population when you use a triplet combination. We did look at patient-related outcomes, and I think going forward we need to look at more of these and show whether or not when we are combining all of these drugs, are we impacting quality of life of patients. In fact, when we use the triplet combination, it favored patient-related outcomes as well in this study. There is a cheaper option, and the cheaper option to RVD is VCD. Bortezomib, as you all know, is going to be generic, or is already generic, in fact. And if you use Cytoxan, that is the cheaper alternative to combining RVD. And there is a trial which has compared VCD to RVD. And if you look at the outcomes, both PFS and overall survival, it does favor the combination of RVD compared to VCD. We do use VCD in a subset of patients, though, specifically those who have renal failure, because you can't use bortezomib. But again, end of the day, I do think you have to use the better combination for patients in terms of life-saving as well as controlling disease much better. There are other alternatives like ixazomib. It's an oral proteasome inhibitor, extremely well tolerated, and we are seeing very nice PFSs of close to 36 months in this patient population. Now, what about the older patient population and continuous therapy versus fixed duration of treatment? There's enough data in multiple myeloma now, and this is close to 1,000 patients looking at 3 different studies, and I'm not going to bore you with the details of this, but the bottom line is all of these studies in an elderly non-transplant patient population favors the use of continuous therapy in this patient population. And this can be demonstrated here. The concern with PFS a couple of years back in myeloma was, well, if you continue patients on therapy, what are you going to do at the time of relapse? So that we started looking at the concept of PFS2. Now, if you're worried about not being able to salvage a patient at their second relapse, your PFS2 should have shortened if you are unable to salvage a patient. But the data speaks otherwise. And in fact, PFS2 also improves in patients where you're continuing therapy, so that when you go forward here, you see that fixed duration as well as continuous therapy, there's really no difference in PFS2, suggesting that in oncology, I think the principles of oncology is give your best treatment up front, try and get the best response, and try and keep them in remission for as long as possible. There's a bunch of different ongoing trials which are going to report out late this year or early next year, which is again going to change how we think about pathways. And that's why, I think it's a good idea to have pathways, but in a disease like multiple myeloma, it doesn't necessarily work because we are changing so rapidly. I sit on the NCCN committee where we try and create pathways, but we really can't because the data comes out so quickly. And I'll show you what we have for our NCCN guidelines. This is the 2018 guideline, and I will tell you that every year we sit doing these guidelines, we have to incorporate new ones because the data is rapidly coming, and these are all phase 3 randomized FDA-approved drugs. They are all high cost. Now, if you look at this is hardly a pathway, and I am in part responsible for this. What we try and say is what the preferred regimens are. We give them a category based on if it's a phase 2, phase 3, no phase 1 data makes it to the NCCN. Part of this is to let CMS know that these are drugs which have been tested in N number of patients, and they have in fact been demonstrated to show a benefit. If you look at this data set, though, it doesn't help an oncologist to say, this is how I need to be treating my myeloma patient, because you have so many different options, both for the transplant eligible as well as the non-transplant. And if you look at the two, actually, they're pretty similar. We're using RVD for the transplant ineligible as well as the transplant eligible patient. So in general, I think most of us think that triplets for induction should be what we should be doing. Maintenance for everybody and continuous therapy should be standard. Can we do better? And we are testing actually 4 drug combinations in the treatment of myeloma, which at this meeting will sound kind of crazy, but I'm going to, by the end of this conversation, hopefully convince you that there may be some merit in doing that as well. What about relapse? Well, the majority of our patients relapse, and as you can see, with every subsequent relapse, the duration of remission seems to be going down. What we've seen is the fact that as patients relapse, so at the time of diagnosis, this is what the genome of a myeloma patient looks like. Very complex. It's not like CML where you have the BCR-ABL translocation and you can use Gleevec and get away with Gleevec and that's about it. That's part of the reason why I think we need to use combinations. But here's what happens to the same patient at first relapse. So this has become even genetically more complex with more deletions, more insertions, more rearrangements, suggesting that if I've used a triplet combination here, there's no way that I'm going to get away by using a doublet combination at the time of relapse because the complexity of the disease is that much more. So there's a bunch of different combination chemotherapies which have been tested in the relapse refractory setting. They've all been pitched against. So it's 3 drugs versus 2 drugs, and it's always the 3 drugs have won. I'm not going to go into the details of this. I'm going to share with you a couple of examples later on. But what we've seen over time is the fact that there's been an improvement in even the survival of relapsed refractory multiple myeloma. And I'm just going to show you this data here. This stops at 2014. And this group of patients includes patients who are refractory to lenalidomide, pomalidomide, bortezomib, and carfilzomib. So it does not incorporate the monoclonal antibody era. No daratumumab here. And if you look at this, what's happened here is the PFS is about still 5 months, but the survival of these patients who are kind of quad refractory, both IMiD, both proteasome inhibitor refractory, their overall survival is about 15 months or so. What we have now with daratumumab in combination with pomalidomide and dexamethasone is a PFS of 8 months. So add that on to that 15.9 months. Our patients are going to live longer. And then you have this new OPTIMISMM data set, which also looks quite nice, wherein you have a risk reduction of about 39% in this patient population, as well as a progression-free survival, which is a median PFS in all patients of 11 months. But if you treat these patients early, their median PFS is about 20 months. Granted, the follow-up in this is only about 16 months or so. So what about the guidelines for relapsed refractory patients? Well, we have so many clinical trials in this space, so all of them become important. Remember that the table that I showed you earlier were usually all lenalidomide-based combinations. The reason I showed you the PVD-DARA, the PVD combination and the PD-DARA is what we typically have in the US population is they are relapsing on len maintenance. So all of those approvals, although we have those approvals, are not quite relevant in the context of multiple myeloma, and we go to a POM-based regimen, whether it's POM-DARA or POM-bortezomib. It could be anybody. It's basically a choice which we have for our patients. So obviously, I've shown you a lot of data, and there's a lot of talk about high drug costs. Specifically, myeloma seems to be singled out because we are using all of these combinations. I'm standing here and talking to you about 4 drug combinations as well. And I'm just going to walk you through one patient. And I'm going to show you what it costs here. So if you induce a patient with a triplet of bortezomib, lenalidomide, dexamethasone, that's what it costs. You give them 4 months worth of that, 4 cycles. Then you go in and do your high-dose chemotherapy and stem cell rescue. Then I've shown you data on lenalidomide maintenance. So these patients need to be on lenalidomide maintenance. And on an average, they live for about 3.5 to 4 years while on len maintenance. And that's the amount of money len maintenance would cost. And then you have the first salvage, and if at first salvage I use KRD, it's going to cost me about $200,000, and then at my second, and with that they have a median PFS of 22 months or so, and then you have Daratumumab, Pomalidomide, Dex, which costs as much as that, with a median PFS of 12 months. So this is the lifetime, which is pretty typical of a multiple myeloma patient going on for 8 years. I'm going to tell you, they live for 10 years, and with all the data that I'm showing you, they are going to live a lot longer as well. So on an average, we have spent $1 million taking care of one myeloma patient. And if you take your 30% rebate and your copays and whatever else, you've spent about a little close to $750,000 on this patient. If you look into what happens with 30,000 new myeloma patients being diagnosed every year, this is how much it costs us to treat patients. This was just 2017 numbers, and what it does exclude is hospital costs, infusion costs, all the lab, all the imaging. I haven't even shown you, I've shown you MRD testing. MRD testing was just approved about 2 weeks back for multiple myeloma, so that's a new test which is going to be used. I have not talked to you about imaging because we've moved away from x-rays and we are doing things like PET CT scans, CAT scans, and MRIs in our patients. But it also excludes, which in my mind is really important, is quality of life adjusted costs as well as productivity in society. And I think when we start costing all of these drugs, we need to start looking at value of care that we provide to our patients, and we need to have better metrics so that we can get the benefits that we see with all of these treatments, and for the payers to be able to pay as well. So we've looked at some of that data in myeloma, and I'm going to share a little bit of that with you here. I'm going to have you look at that end of the slide first. And this is what's happened this is the average control patient in myeloma, but over the years, the bottom line is survival for multiple myeloma patients has improved. And the reason for this improvement is shown out here. Now this black bar here, which you can see quite well, is an adoption of novel therapies. Ever since we started using novel therapies, this has translated into an improvement in outcomes, an improvement in survival of patients with myeloma. Now just focus on this slide here. If you look at the multiple myeloma related costs, and 2004 onwards is when we started adopting new drugs, certainly the cost of myeloma care has increased, but it has not increased as much as all other health-related costs out here. So this is just cost of drugs. So although I've shown you combinations of high-cost drugs, when you really drill down and look at this data, it does not really show that it's all because of cost of drugs. A lot of it is other health-related costs, which can be quite significant as well. What is new in myeloma? Well, I've shown you combinations, but I can tell you that what's coming down the pike is even more expensive than what we have right now. And I'm not going to go into the details of this. I'm going to highlight a few things which I think are going to impact how we take care of our myeloma patients. We know that BCMA is a great target for myeloma. It's a protein which is present on all myeloma cells. And there are different approaches to using BCMA-targeted strategies. We have this, which is a conjugated antibody, GSK 2857916. Now, this antibody has been used in people who have seen everything which is available, FDA approved and available for myeloma right now. And as a single agent, we are seeing an 8-month progression-free survival with this monoclonal antibody. It's still early in its development, but this is something which is going to get approved as well. What about other strategies such as CAR T cells? Now, CAR T cells in multiple myeloma are being studied, and I'm not going to go into the details of this, but if you take the price of the already approved CAR T cells, such as Yescarta and Kymriah, they cost anywhere between $350,000 to $500,000 just for the product itself, and that's not even taking into account what it costs for us to get patients in and actually give them these therapies. Having said that, with this kind of therapy, we are seeing 90% response rates in our patients with relapsed refractory multiple myeloma. And if they have MRD negative disease, they've had remission durations of 18 months or more, which we have never seen in myeloma before. So these are advances which we absolutely need to continue to work with, because this is what's ultimately going to get to a platform wherein we should be able to cure a subset of myeloma patients. I'm going to give you one example of a clinical trial which I've been involved with. This is Denosumab for bone disease. Patients with multiple myeloma have horrendous bone disease. This was compared to the good old zoledronic acid. It's a bisphosphonate in more than 1,700 patients. And when we look at the data in terms of skeletal-related events, whether you use Denosumab or zoledronic acid, it was equivalent in terms of bone-related problems. When you look at progression-free survival, though, and we can go into this, there was a significant improvement in progression-free survival for patients who actually had Denosumab. Now, if you think about Denosumab, there are a few factors here, one of them being renal toxicity. I already mentioned kidneys in myeloma, really important part of myeloma. And Denosumab is extremely safe when it comes to renal toxicity in myeloma, and this was shown in this large trial. We actually did a cost-benefit analysis here because zoledronic acid is generic. Denosumab is obviously a newer drug, and the sticker price for zoledronic acid is $70. The sticker price for Denosumab for us right now is $2,000. So we went ahead and did this, and when you look at the net monetary benefit, we did see about $6,000 in terms of benefit, because what sticker prices don't take into account is the fact that when my patient comes in to get zoledronic acid, I need a 1-hour infusion time. I need my nurses giving hydration to a patient, and it takes them 15 minutes, but for myeloma, I do not use zoledronic acid over 15 minutes because of kidney-related issues. I give it over 45 minutes. Denosumab, on the other hand, my practice nurse goes in, gives a shot, and out. So at MGH, we've actually adopted using Denosumab because of the cost saving. And this is the part which I think we all need to understand, even within our institutions. We look at buckets which are very separate. Pharmacy will look at one bucket, the hospital looks at one bucket, and I think you have to have a more global view of how we estimate costs and where the cost savings are. So I think in terms of myeloma, the combinations will allow us to improve response, and I do think that's going to translate into us curing a higher fraction. We are using drugs with different mechanisms, and we can identify high-risk disease as well. But I do think for oncology in general, we need to look at it from a macroeconomic state. And I will tell you, we're beginning to do more and more work such as this, more so in myeloma. And the one thing I have learned as I've been more involved with this now is the economists are way ahead of us. We as physicians have a harder time understanding, and we focus on how much does the drug cost. And we are a little bit behind in times in trying to understand the value of care that we provide. And the other piece is I don't think we've published enough. Those are harder metrics, but we need to look at more of this data in terms of what does it cost to actually save the life of a patient, and how much of a benefit, how much of a societal benefit is it, and that's how we need to look at oncology care more. We've done that in myeloma somewhat in the context of bortezomib and lenalidomide, and if you look at the yearly drug costs, which are offset by the benefits, so if you keep a patient in remission, and if you keep a patient of multiple myeloma on maintenance for 4.5 years, you're keeping them out of hospital for that much longer, and that does impact how patients do. So I think in the future, we need to do more health-related quality of life kind of adjusted studies in proving that some of these high-cost drugs are good. The other thing which I'd mentioned earlier was the 4-drug combinations, and I showed you that continuous therapy is what's the standard of care right now. But when we have tests like MRD to allow us to guide our treatment paradigms, I think those tests are also going to allow us to de-escalate treatment. So if we can really deepen responses in people, maybe we're going to say this is a subset of patients where I do not need to continue treatment on, and de-escalating treatment is also going to, one, decrease morbidity, but also save costs. So with that, I'm going to... All right, thank you so much for your attention. I'd be happy to answer questions.
Can you stay up here and take some questions?
Sure, absolutely.
All right, thank you. So we have about 5 to 10 minutes for questions for Dr. Raj. Please start with you, Dr. Wasserman.
Thank you for an amazing talk and incorporating all those new drugs. I want to challenge one of your comments that as a super expert who can guide us, it is how we can think differently about how we get guidelines updated quicker to pathways. So, at City of Hope, where we have 32 community sites and doctors see different diseases, having at their fingertips this knowledge in a way that you presented it, what the cost is, what the overall survival is, what the difference is to the patient and the regimen, we need to get that more real time to the bedside so that your genius is helping everybody or others like you. So we need some different approaches. It might be a monthly update or every 2-month update to the guideline right into the pathways, but we need to do better, and this knowledge is just essential. And I really come from it personally with a brother-in-law who is now 11 years out on maintenance, but during several months doing the IMIDs, whether it's Lenalidomide or Rev, $2,000 a month copay for a retired school principal married to a teacher. They're now selling their house and moving in with their kids, and he's grateful to have 11 years feeling great, except buzzed on Decadron intermittently, but these costs are important to patients, so how we get them paid is important, your work justifying them is important, and then how we get the best treatments to patients. So thank you so much.
Thank you for that question. I think that, I do think we're not doing a good enough job of communicating this. And I do think we're still at the beginnings of us understanding this. As I mentioned, there is a little bit of a gap between how physicians look at it. And I was a little bit, when you are at ASCO, for example, the questions which are asked by physicians, they really don't want to pay. It's us who are somewhat the barrier. The good news, I think, is with ASCO, we are going to come up with guidelines. We haven't incorporated the cost. What we are doing with NCCN, though, is looking at efficacy, toxicity, knowledge, and how much does it cost. So there is a graph out there. I will tell you, sitting on the NCCN committee, I don't find that very useful, because for oncology, everything, the cost is sky high, efficacy is also high, and then the toxicity changes. So I don't know if that's helpful, but as we keep doing more guidelines and standing up to some of our ASCO colleagues actually, and making cost and the benefits a part of our conversation, including them into our guidelines, or at least in the discussion of our guidelines, is something we all need to work on. ASCO is still not agreeable to doing it, but we do need, I think we need as a voice to say that we have to have this as part of the conversation. The other thing I will say is we need to work with our economists, because they have a completely different perspective, and the more we get their perspective into the medical world, the better off we are going to be.
So you're absolutely right. Having just finished 4 years on the ASCO Board of Directors, I was really pushing this as well and have often shut down. But I'll be the new JOP editor as of January 1st, and I invite articles, because we are ASCO, we are representing our patients, and many of us on the front lines see it, and we need to share that with our colleagues. So please, I will be talking about an article.
Excellent.
Joan brought up a question yesterday with the AML about the referral from the community. Is that a challenge that you grapple with diagnosis out in the community? And do you have any ideas on that?
Yes. So, what's happened with myeloma, a little bit different from AML. AML, you tend to refer to an academic center because it's hard to provide the kind of supportive care out in the community. With myeloma, it's a little bit different. Because of all of the drugs that we have approved now, people actually will treat out in the community as well. My recommendation in general is always refer to an academic site, and then we, work with community oncologists and take care of these patients as much as possible in the community, because that's how it should be. The only reason I say always refer to an academic center is there's so much happening in myeloma, and for somebody to keep up with all of this is so hard, and it's so important to make sure that our patients avail of all of this information. That's the only reason, but it should be a partnership of community with the academic site working together.
Thank you.
Thank you.
Join me in thanking Dr. Raj, please.